5 years. So if in case something like retinoblastoma is seen above 5 to 6 years, you really need to reconsider the differential diagnosis and diagnosis to be sure that it is really retinoblastoma. So it is that rare in even older children or even in adults. So it is almost near to 0% in adults.
So does it happen in both the eyes or does it happen only in one eye?
Coming to your first question, how do we actually see it or how do we pick up it? We should not miss it. So first thing, because it is a pediatric tumor, mostly small kids suffer from this. So बहुत बार ये ऐसे होता है कि we need to notice few things. Adults का कैसे होता है? They generally tell you the complaints. They will have something, they will communicate with their relatives, parents, or maybe the doctor directly. But ये pediatric है, so the parents, grandparents, or people around the child need to notice few things, and that is how it is generally diagnosed. So the common things how we need to like be vigilant. So what we see when we need to be sure that okay ये तो rule out करना चाहिए retinoblastoma नहीं है ना. First thing is there any history of retinoblastoma or for that matter any eye condition which occurred in the parents in their childhood. Sometimes अभी कैसे होता है ना last generation के वक्त there is not much of documentation which is available. So sometimes there are people like when we see the parents of the children, one of the parent may have one eye missing, and when we ask them कि ये क्या हुआ, आपको क्या हुआ, why the eye is not there, so they tell कि कुछ तो बचपन में हुआ था, we don't know the details. So that is one thing. If parents are having some eye condition since childhood, the eye was removed for whatever reason, so you need to find out before having the kids if that what was the reason. Next thing, so that is the first risk factor जब vigilant रहना चाहिए when the child is born. Next, सबसे important and commonest जो presentation है retinoblastoma का, उसे बोलते हैं leukocoria, which is white reflex. तो generally it is seen, हमारा जो pupil रहता है, it is generally jet black. So there is no white reflex from that black portion. So in retinoblastoma, the reflex will become white. Leuco is white. So leukocoria, white pupil. So white pupillary reflex is the most common presenting feature which is seen. So why is it seen? Generally retina की वजह से जो red glow या jet black pupil दिखता है because of the retinoblastoma का mass. It is seen white, and आजकल because we have a lot of use of the photos from mobile and everything, noticing leukocoria or white pupil reflex has become more easier because sometimes even from the photos we can make out the difference of reflex in two eyes. So it is different than the red reflex sometimes by mistake which we get from the photos. It is not like that. It is generally on particular angle, and that too many of the times if it is only in one eye, the difference is very evident between the two eyes. So that is one thing. Any squinting in children which is unexplained, it is better to consult a doctor and make sure that squinting is not because of any intraocular, जो globe के अंदर कुछ mass है, because of that squinting is not there. So squinting, ल्यूकोकोरिया, ये दो सबसे कॉमन चीजें हैं जिससे पेशेंट्स प्रेजेंट करते हैं, एंड दीज आर द कॉमन थिंग्स व्हिच इवन पेरेंट्स और पीपल अराउंड द पेशेंट विल नोटिस एंड कम बैक. अदर फीचर्स आर देयर, बट दोज आर most of them we notice after the examination when the tumor is still inside the eye. Once it advances, then big mass दिखता है, it is like eye proptose, like eye आँख पूरी आगे आए जैसी दिखती है. So those are the things, but early signs, yes, white eye reflex, squinting, these two things are very common, which even parents can notice and bring their child to get examined by expert ophthalmologist. Specifically, I would suggest some ophthalmologists who have a special training in eye cancers, so ocular oncology.
So tell me something, does the vision also fall because of retinoblastoma happening? Because normally क्या होता है, कहते हैं ब्लैक बोर्ड नहीं दिख रहा है, क्यों नहीं दिख रहा है? क्योंकि बच्चे की आंख शायद वो है, या वो ठीक से नहीं देख रहे हैं, ये वो मतलब
Yes.
सब
I would say कि अभी because retinoblastoma surely does affect the vision, but because the age group is 0 to 5, तो ब्लैक बोर्ड ना दिखना या पेशेंट ने नोटिस करना एंड देन टेलिंग द पेरेंट्स कि मुझे कम दिख रहा है occurs slightly less because of the age group in which it occurs. So वो भी most of the times is noticed by the parents, grandparents or somebody who's taking care of the kid. Especially if it is bilateral, जो दोनों आंख में है तो surely it will be more evident. एक आंख में है तो defective vision कई बार unnoticed जाती है because the other eye is taking care of it. But yes, मतलब आंख में कमजोरी, like दृष्टि में कमजोरी is one of the main features of retinoblastoma, especially in small kids. क्योंकि छोटे बच्चों में जो retinoblastoma होता है, that is exactly it occurs at the center of the eye, which we call it as macula. As the age progresses, मतलब छोटे बच्चे एकदम 0 to 6 months के अगर they present with retinoblastoma, the tumor will be right there at the center of the eye where the vision is there. So yes, vision gets affected, but a patient coming with defective vision is less likely because of the age group.
So suppose there is a delay in finding out that there is retinoblastoma. Does that cause the second eye to get affected, or does retinoblastoma come in both the eyes at the same time? What is the thing about it?
Generally, when we there are multiple studies about the incidence of retinoblastoma worldwide as well as in India. So what we have studied is earlier is the presentation of the retinoblastoma is most likely to be something which is hereditary retinoblastoma, and that has more chances of becoming bilateral. But that bilaterality या दोनों आंख में आना is because of the retinoblastoma per se, एक आंख से दूसरे आंख में नहीं जाता है. So it is because the gene is defective, it is occurring in both the eyes. It is not spreading from one eye to the other eye. ये symmetrical भी हो सकता है, asymmetrical भी हो सकता है. Most of the retinoblastomas जो 18 months या 24 months के पहले diagnose हुए हैं, most of them are hereditary and most of them are bilateral. Maybe symmetrical, no asymmetrical, but most older the kid becomes, like around maybe about 2 to 3 years, more chances of the retinoblastoma being unilateral. Unilateral is occurring only in one eye. So those are the things. It doesn't spread from one to the other, but basic pathology ke wajah se, yes, it can be bilateral, especially if it occurs in younger children. We need to be more vigilant.
So you are saying that if the parents have had some eye problem in the early ages, which may be documented or not documented, then the chance. So that means, are you conveying that it can be hereditary?
Yes, yes. It is proved that retinoblastoma is hereditary. Heritable things do get transmitted to the kids. So any retinoblastoma kid transmitting the retinoblastoma disease to the next generation, the risk is obviously there. There are many labs which are coming up which do the genetic study, because जो mutation जो बोलते हैं ना genes में, it can be something which is hereditary, like autosomal dominant जो previous generation से आया है, और sometimes it is a sporadic mutation जो वो specific person में, specific kid में हुआ है. It is not from parents but sporadic mutation हुआ है. But even these things are heritable, and nowadays there are multiple labs which do the genetic workup. So it is always good to do the genetic workup before having, like especially in the parents who had history of one kid with retinoblastoma, or they themselves had retinoblastoma and they are retinoblastoma survivors. Because see, earlier there was not much of treatment which was available, so the mortality rate was very high. But with advances of the treatment, definitely the patients are surviving. They are able to like there are many patients where we can even salvage the eye. and vision. So these patients, once they become adult, I feel they need to get the genetic things checked up before like taking a chance of the kid. And obviously that is absolutely not a contraindication to have kid, but you need to be very vigilant, and like you need to screen the child in time to rule out retinoblastoma in those cases, high risk cases.
So you mentioned just now that the vision can still be maintained even if you have retinoblastoma. It doesn't mean that your vision will be totally lost, even after treatment or something like that.
Yes. So it depends on where the primary tumor has occurred. So because it is the retinal tumor, it is very important to know कि tumor कहाँ से आ रहा है. As I mentioned, lesser is the age, tumor posterior folia center of the retina से ज़्यादा आता है. As the age progresses, it slightly comes like the origin of the tumor slightly comes towards anteriorly, like goes away from the center of the vision or from macula. So in kids where retinoblastoma is diagnosed when the tumor is small and at periphery, and when the macula or the center of the retina is not affected, yes, vision can surely be maintained. But the technical problem here is when the tumor occurs in periphery, it is very difficult to actually catch the tumor early. Because see, every child we do not do dilated examination very repeatedly unless we are suspecting कि इसमें high chances of retinoblastoma है. तो ल्यूकोकोरिया या white pupil reflex जो है वो भी काफी बाद में आएगा. तो almost 50% of the eye की cavity tumor से जब भर जाएगी तब वो reflex आएगा, and even the vision will get affected late. So the presentation sometimes becomes late in those kids where peripheral thing is there. So if that eye is salvaged and the tumor regresses after treatment, yes, even vision, at least some partly can be maintained in few patients. It's not that every time you need to sacrifice the eye or vision or even the patient. So as we tell now, in any cancer patient, the protocol for our first preference is making the patient safe. The patient should live. So that is our first preference. Second preference is organ salvage, which is we should be able to salvage the eye. Eye sacrifice नहीं करना है. Enucleation या eye removal surgery avoid करने की अगर possibility है, so we will try that. That is our second goal. And third goal is salvaging the function. In our case, salvaging the vision. So that is how our preferences are. Because if patient is there, then organ या vision है या नहीं है, that question arises, and that is how the preferences go while taking care of any tumor management.
Yeah, because we've seen most of the time we see children with who have lost their eye and the eye has been removed and there's a socket over there and all that, and it feels very painful, and we don't know whether it is because of the late diagnosis or because of what reason. So, is there any preventive checkup for that except for the parents having cancer? Some eye deformity or in the early stages, but is there anything that one can do in the early ages of the child?
I wouldn't practically suggest for patients who do not have any history of like high risk features or high risk history for retinoblastoma, like any normal kid, no history of retinoblastoma in family or siblings or anyone. I wouldn't suggest that every child should undergo a preventive checkup, but we can have a low threshold to see ocular oncologist or eye doctor who is specialized in cancer in case you suspect something. It is okay to have 99 healthy children getting examined by a doctor, not to miss that one who actually has it. But in our economics and everything, subjecting every child without any history or high risk feature may not be a practical approach in that case.
Yeah. So, how common is retinoblastoma? How often do you see children having retinoblastoma? And is there like a sex this thing also that uh, children, male
The
children?
magnitude of the problem, it will actually, yeah. So whatever pediatric tumors happen, uh, retinoblastoma constitutes around 3% of all pediatric cancers. And pediatric intraocular tumors, retinoblastoma is the most common thing. So it is not very rare, but it is most of the times not diagnosed in time because people are not aware that even I can have cancer. And that too, especially in pediatric age group, people feel that cancer is a disease of elderly.
Yes.
So that is another thing which we need to stress, that yes, it does occur in eye, and retinoblastoma is a childhood cancer. So these are two things which are not very commonly known by patients.
Okay. So, like you said, that the diagnosis is done by seeing the eye and the white
Reflex.
reflex to know whether, so suppose once it has been diagnosed that the person has retinoblastoma, can one wait for some time for it? Does it go away naturally sometimes, or it just doesn't go away naturally?
Just for the diagnosis, for completion of the diagnosis thing, I would just add something and then I'll go to this particular question. So for diagnosis, other than symptoms which are told by the parent, symptom is something which the patient presents to a doctor, and signs is something which doctor sees in the patient. So the most common symptom is leukocoria, which is white pupil and this thing. So once the doctor sees the patient, what is important? We need to dilate the pupil, which is the in the central part which needs to be dilated, so that we can have a better view of the retina. The B scan or the ultrasound of the eye gives a clue that there is a mass, and it shows something, high reflective spots, which is calcification. So these are things which the doctor needs to confirm if they are present or absent. Sometimes CT, MRI, these imaging modalities are also needed, where we actually need to image the child to see if the tumor is still there inside the eye or it has gone outside. Because in my part of country or like place, I would say there are many people who come with a huge eye which was neglected, so we need to see what is the extent of the tumor. So these are the things which we need to evaluate, and then we can write down the protocol of the management of the disease. Retinoblastoma is generally a very high grade tumor. It multiplies at a very rapid rate. So I would suggest that once the diagnosis is done, it is wise not to wait even for a day.
Okay.
So
So, like you are saying that they come with protruded eye and all that. तो उसमें क्या होता है, क्या कैंसर आपने कहा एक आंख से दूसरी आंख पे नहीं जाता है, लेकिन वो आंख जो जहाँ फैल गया है, जहाँ बड़ा हो गया है, जहाँ साइज प्रॉब्लम हो गई है, can that cancer become a secondary cancer in any other part of the body?
yes, yes. So there are two like generally modes of spread of the disease. First thing is eye की जो optic nerve रहती है, it is in connection directly to the brain, because that is how we get the vision signals. So जो CSF होता है, the fluid around the nerve and brain, the metastasis कई बार उससे जाता है. So there can be something like intracranial extension along the optic nerve, and the CSF may get involved. So that is one. Other thing is it can have a hematogenous, that is through blood spread. So it may metastasize to the bone marrow also. So generally, when we image, agar bade aankh hai and when we image, so most of the cases where aankh ke bahar aaya hua dikh raha hai, but the optic nerve is fine, most of those kind of patients do have a higher risk of bone marrow metastasis. and the patients in whom it has not come out, but the optic nerve thick ho gayi hai. So these are subtle signs where we actually come to know ki, acha, this is going somewhere else. या फिर sometimes secondary glaucoma हो जाता है because of the tumor and everything, the intraocular pressure बढ़ जाता है. That is also, recent studies have shown that that is a high risk factor, how the tumor may like spread towards like through the optic nerve. So these are few risk factors. Yes, it does have a metastasis. Sometimes lymph node भी lymphatic spread भी होता है, lymph nodes भी affect हो जाती है. But so CNS like brain metastasis, bone marrow metastasis, lymph node metastasis, these are the things which are there like commonly.
Yeah, so though you are saying that vision can be restored, but would you also like to say that in 90% of the children it doesn't get restored?
I would say the percentage will differ according from area to area. It depends on how early the patient presents. So earlier the presentation, better are the chances of globe salvage, vision salvage, and obviously the patient is but when rural area or some like peripheral areas where there is not much of awareness about the disease in patients, even in the local doctors who are providing the primary care, so wo logo mein bhi it is very important to spread the awareness that ye screening kaun se, these are the features and ye screening jaldi karna hai, and then send the patient quickly. And even relatives need to there. In my area I have even seen the gender makes many a times the decision if the patient is going to go to the higher center or not.
Yeah. So are you, because I don't see much talk about retinoblastoma. I mean, we work with retinoblastoma patients, so we know a little about it. But
Yes.
in general, I don't see much, like no posters or no awareness campaigns or no educational work on, these type of things. So, do you think it's possible for people like you to, make small leaflets which can be distributed to the patient, to everybody who comes for any?
Yes, I personally feel even with the like public in general, the non-medicos or the patients and general public, in addition to them, we need to make even other professionals, even medicos who are not ophthalmologists, who are not like ocular oncologists, or like maybe general practitioners, the people who work in the PHCs or remote areas, they also need to have a better awareness about the disease, so that, see, it is very well known proverb that the eyes will see what your mind knows. So unless you know about the thing, even if you know the see the leukocoria, you will not notice it. So I think even those people also need to get a bit of awareness things in addition to normal public or the patient's relatives and everyone.
Okay. So now we've discussed a lot about early symptoms and how to recognize it and all that. But the child comes to you and the treatment has to start. So what are the processes or the steps for the treatment?
Yeah. So first thing which we generally do is the EUA, which is the examination under anesthesia, because we know that this is a childhood cancer. We need to be sure about the extent and everything. And like an adult, the child is not going to cooperate. So first thing is if essential imaging, which is the sonography, CT, MRI, whichever is the relevant to the patient, then subjecting the patient to the examination under anesthesia, because as I mentioned, if it is bilateral, sometimes it is asymmetrical. So for example, I will say a small example, maybe one patient is having a very advanced retinoblastoma in one eye. So I take a decision of enucleation. Okay. But I have missed the small retinoblastoma, maybe early 1 or 2 mm of the mass in the other eye. So if I enucleate the advanced retinoblastoma eye and leave it like that, the other eye is going to progress. So EUA is important even if the retinoblastoma is very evident in one eye, because the other eye also deserves equal attention at least in the initial examination, so that we are not carried away with the more advanced disease. So first thing will be EUA, which is examination under anesthesia. If I see any clinical risk factors, high risk factors like proptosis, there is secondary glaucoma, there is new vascularization of the iris, there is something which is like showing me that it has some involvement, then I would also subject the patient to the CSF cytology to rule out any malignant metastasis and bone marrow biopsy. Nowadays, even PET scan may have a role, but at least these two basic things will decide the course of our management. So now once we are done with the EUA, we actually know at least the grouping and kind of staging of the disease. So that once we are sure about the grouping, staging and final diagnosis of the disease, then we prepare the treatment protocol for the patient. So maybe I would now shift to what all possible treatments which are available for the disease. So possible treatments earlier days was find the retinoblastoma, enucleate, and that's the end of the story. But nowadays, then there was a era when radiotherapy came in a big way. But radiotherapy did have its own side effects. It increased the risk of the second malignancy like Ewing sarcoma. And now today is the like era of chemotherapy. It is very well known fact in last 1 or 2 decades is chemotherapy, the retinoblastoma wonderfully responds to chemotherapy. So chemotherapy nowadays, the ways of giving chemotherapy are changing with the advances. The earlier chemotherapy was intravenous, which is you give like how we give other medicines by intravenous route. Now, because we give intravenous chemotherapy, the obviously the drug goes to all the organs. It does have side effect on the other organs, which includes increased risk of infection, then decrease in the platelet count, so increased bleeding tendency, decrease in the hemoglobin. ये सब होता है. So the other thing which came up is intra-arterial chemotherapy. तो selectively interventional radiologist के help से we go there in the artery, ophthalmic artery के यहाँ पे, and then वहां से chemotherapy is given. Obviously, the maybe as a bigger picture, it is slightly expensive. There is a lot of technological and expertise need which is there. But obviously, people who are affording and for whom the facilities are available around, it is a good way. Other things are chemotherapy like inside the eye injection, around the eye injection. These are adjuvant things which are done in addition to the primary treatment.
And then you remove the eye in any case, in spite of all the treatment.
Not like that. No, there are many patients in whom we can actually salvage the globe. Salvage the globe as in we can maintain the globe there. It may or may not have vision, but at least having the primary organ in place surely has a psychological relief for the patient and the relatives.
Okay. So even how much time do you think the whole treatment takes for?
So see, if a simple retinoblastoma who is responding well to chemo, and if we assume that chemotherapy is going to be the end of the treatment, then we generally give 6 cycles of intravenous chemotherapy, which are 3 to 4 weeks apart, preferably 3 weeks apart, but sometimes because of the drop of hemoglobin and everything, it may become 4 weeks gap between two. So it is around 18 to 20 weeks, which it takes. But the thing is, even if the treatment stops, the EUA or examination under anesthesia needs to be continued for a longer period, because children do have very high tendency of recurrence of the tumor. So these recurrences, small recurrences, we need to be like vigilant about, and those small recurrences can be taken care of by the local treatment like transpupillary thermotherapy or photocoagulation. So basically you burn those tumor cells which are there.
So you can't do that in the beginning itself, burning of the tumor cells?
It does have a lot of inflammatory response. So it is done from the around third cycle onwards, all these adjuvant treatments, once we reduce the tumor, we actually start seeing the areas where we can actually do the thermotherapy. So that is done when the chemo is done. So my general protocol is, even if we are giving chemo to the child, before every chemotherapy, so every 3 weekly, the child will undergo examination under anesthesia, which will be followed by chemotherapy. So I get to know how the child is responding to the chemotherapy. And in any case, if I see no response or it is worsening, I may need to take a decision of enucleation early rather than waiting for like maybe 6 chemo cycles and then taking a decision. And maybe even counseling of the parents also becomes easier when you actually see the progress of the tumor, progression or regression, whatever, hopefully regression every time. So the counseling and in general mental preparation of the parents for a particular therapy, especially if the patient needs to undergo eye removal, they need some time to actually accept that decision. So
So,
that surely helps.
I mean, an approximate cost about the for treatment in.
The other thing I would like, if the child is coming with orbital retinoblastoma, which is the eye has become bigger, it has spread, so it needs to be the child needs to undergo multimodal treatment, which is neoadjuvant chemotherapy followed by surgery, followed by radiation, followed by adjuvant chemotherapy. So this will take like many months to actually complete the treatment. And obviously the like even post treatment, we need to fit the customized prosthesis for a better this thing, and then follow up. So it will even the cost will, I guess, depend on the stage of the disease, what you are actually choosing the treatment form. If you are choosing intra-arterial, it will have cost in lakhs, whereas you are choosing intravenous chemotherapy, and if the child is going to get cured only by that, it won't be as expensive as intra-arterial. And there are many schemes where even these chemotherapy regimes are provided in the like Mahatma Phule Arogyada Yojana, and all those sometimes do cover the chemotherapy of these tumors.
Oh, and what about the prosthesis? We help the patients by providing them a prosthesis, which has no vision or anything except that it makes the face look normal.
Absolutely. In my opinion, ocular prosthesis is something which is not actually a cosmetic or aesthetic thing. In my opinion, it does have a functional value, because many of the times we have seen the children become introvert. Even the parents do not want to expose the child to major social gatherings because they have that कमी लगती है कि अरे face is not presentable. So it is not only the looks, it actually the day-to-day life, confidence, everything changes because of the prosthesis. And yes, obviously prosthesis अगर time पे बिठाया जाए, that to customized prosthesis बिठाया जाए, तो even the socket health is well maintained, and it stays healthy. And obviously when the child grows to an adult, obviously the cosmetic and aesthetic requirements increase, and that time again going back, doing the surgeries, making the space and putting prosthesis becomes really painful. So if we take care of the socket from the beginning, when we are doing the primary surgery, doing the surgery along with the implant, and then subjecting the child to customized ocular prosthesis is obviously a very important.
So, what is the availability of prosthesis? I know in Bombay because we are working on it and it's available. But are these prostheses easily available across the country?
Nowadays, the person who actually prepares the customized ocular prosthesis is called ocularist. Nowadays, with increase in number of ophthalmic plastic surgeons, the requirement of ocularist and the awareness about this customized ocular prosthesis is also increasing. So even the number of ocularists has increased. So even though like my city does not have a trained ocularist, one ocularist from Hyderabad comes here and he does the prosthesis. So it is something which is non-emergency. So even small second tier cities also can actually club the patients and call some ocularist who will give a good prosthesis, or else the patient can travel to bigger cities. But surely the ocularist availability is becoming better when compared to people like in the maybe last decade. It is surely better.
What about eye transplant? Does it help in getting vision?
See, currently what we have like is eye transplant is we actually transplant only the cornea, the front transparent part. And here when we are removing the globe, there is no role of cornea being transplanted. So unfortunately, when the eye is removed because of the retinoblastoma, the eye transplant does not have any role, because we need a functioning posterior segment retina and everything to fit the cornea, and then the patient starts seeing. So it does not have a role in the retinoblastoma per se.
It's so overwhelming to hear children suffer so much that, but I'm really happy that you explained so many things to us which we didn't know. Is there anything that
I
I've forgotten to ask you which you would
Yeah,
like to add
I
on?
would like to add another thing. So when we are actually enucleating the eye or removing the eye, it is very important who reports the histopathology. The globe का histopathology कौन report कर रहा है? Is the pathologist ably trained in reporting such specimens? Because there are so many things which actually depend on the pathology report. So when we have a retinoblastoma, we have two types of risk factors. First is clinical risk factor, other is histopathological risk factor. Okay. So clinical risk factors, the doctor who is treating, the ocular oncologist who is treating will surely get to know. But pathological risk factors need to come from the pathologist who is actually sampling the eyeball or reporting the eyeball. So I feel it is very important to contact ocular oncopathologists. There are national reporting centers also, and of course, like I have trained oncopathologists whom like with whom I work. So I have communicated these are the things which I want in my report, because these are the things which are going to decide my further management. So earlier, I'm just giving a small example. Earlier, what they used to see, अरे आंख के बाहर नहीं आया है, the cut section where I've cut the optic nerve is free of the tumor, that means we are safe, which is not the case, which has been come up with few, it's not very recent, maybe last decade also, like the lamina which is there just which connects the eyeball and optic nerve. So even if optic nerve transaction is not like affected, but the tumor is has spread post lamina, we still need to give the patient adjuvant chemotherapy, because there are chances the hematogenous spread हो सकता है. I mentioned ना कि hematogenous भी spread है and along the optic nerve. So these are two different mechanisms by which the tumor is going to spread. So the importance of good trained ocular oncopathologist is equally important, because our management and the pattern how we are going to follow up the patient is going to depend on these things. So communication with the pathologist that I want reporting, अभी laminar spread है कि नहीं मुझे बोलो, vortex veins है कि नहीं, like scleral invasion है कि नहीं, choroidal invasion है कि नहीं. If I ask, the pathologist will tell कि ये है या नहीं है, and accordingly I need to change my treatment. So it's treatment of retinoblastoma, I feel, is a teamwork. First one is ocular oncologist, the eye cancer specialist. Second one is surely a pediatric oncologist who is going to administer the chemotherapy, decide the doses, manage the complications arising out of chemotherapy. Then pediatrician, radiation oncologist, because sometimes radiation is needed, sometimes plaque brachytherapy is needed. In plaque brachytherapy, radiation physicist is also needed. And then oncopathologist, and lastly ocularist. So it is a whole team which makes a difference in one patient's life, and it's not one person who is going to make a difference.
Yeah. Thank you very much, Dr. Aditi. We've taken a lot of your time, but we've also come back very enriched after your talk, because there's so many things, so many doubts that we had. And we actually had the doubts, मतलब मालूम ही नहीं था कि ऐसा भी होता है. ऐसा हम लोग सोच रहे थे हाँ बस यही है and all that. तो आपने कई सारी बातें बताई हैं जो कि जिससे कि हम लोगों को भी समझ में आ गया, और शायद हम लोग को जब हम जनरल पब्लिक से बात करेंगे या पेरेंट्स से बात करेंगे तो ये बताने में आसानी होगी.
Surely I'll be like delighted to help you in spreading the awareness about retinoblastoma.
Thank you very much. We really need dedicated people like you to do that. And thanks on behalf of all of us at WeCare and all our patients. A great, I think you've answered so many questions which we never even thought would be there. And so all our queries have been taken care of. And thanks a lot, Dr.
Thank you so much for making me a part of this, like I would say, a discussion.
Thank you. Thank you.